Good day, everyone. My name is Mary Ann Grace Obrar. I am a BS Nursing Level 3 Section D student from the University of Western Philippines. And for this report, I am joined with Miss Kimberly Del Rio from Section B, and together we will discuss our topic called the Acute Coronary Syndrome, or ACS. Alright, so for a brief overview, we all know that the cardiovascular system consists of two main components, the heart and the blood vessels. The heart is a muscular pump that provides the pressure necessary to propel blood all throughout our body. The blood vessels rather are a closed system naman of tubes and carry blood. So the cardiovascular system begins its activity when the fetus is barely 1 month old, and it's also the last system to cease activity at the end of each of our lives. And the heart, arteries, veins, and lymphatics make up this system. These structures transport life supporting oxygen and nutrients to cells, remove metabolic waste products, and carry hormones from one part of the body to another. However, despite advances in disease detection and treatment, diseases of the heart and circulatory system are one of the major causes of death worldwide. So, ACS, or acute coronary syndrome, remains a leading cause of death globally, and with rising prevalence, particularly in developing countries such as the Philippines, including the Philippines, due to lifestyle changes like increased smoking, unhealthy diets, and sedentary lifestyles. In the Philippines, also, cardiovascular diseases, including ACS, rise to becoming a significant burden to its people, while data on the exact prevalence of ACS in the Philippines is limited. Available studies suggest a substantial impact. Alright, so enough with the chitter chatter. Let's get straight to the point. So, what is ACS, or what is an acute coronary syndrome? Acute coronary syndrome is an emergent situation characterized by an acute onset of myocardial ischemia that results in myocardial death through myocardial infarction if definitive interventions do not occur immediately or do not occur promptly. ACS usually results from the buildup of fatty deposits on the walls of blood vessels that deliver blood, oxygen, and nutrients to the heart muscles. These fatty deposits, that is shown on the picture over there and is colored yellow, it is also called plaque. So the blood vessels that supply the heart are also known as coronary arteries.
What are the different types of acute coronary syndrome? There are three types of acute coronary syndrome: the non-STEMI, STEMI, and unstable angina. Non-ST elevation myocardial infarction, or non-STEMI. This type of infarction result in the formation of a thrombus that does not result in a sustained complete occlusion of the coronary artery. This patient usually present with prolonged chest pain. Biochemical marker via blood tests will be elevated outside the normal parameters, and a diagnosis of non-ST elevation myocardial infarction will be made. If the ischemia does not result in myocardial cell necrosis, biochemical markers will not be elevated outside the normal parameters, and the diagnosis of unstable angina is made. In short, a non-ST elevation myocardial infarction is a type of heart attack where a blood clot partially blocks a coronary artery but not completely. This means blood flow to the heart muscle is reduced but not entirely cut off. So if a blood flow is reduced but no damage has occurred to the heart muscle, biochemical markers will stay normal, and the diagnosis is unstable angina, or a warning sign but not yet a heart attack. So if there is heart muscle damage, it is classified as non-STEMI, as shown by elevated biochemical markers. ST elevation myocardial infarction, or STEMI. These result in the formation of a fixed and persistent clot that causes the complete sustained occlusion of the affected coronary artery and subsequent cellular necrosis and damage to the cardiac muscle. These patients are usually present with prolonged more than 20 minutes chest pain and persistent ST segment elevation. Urgent revascularization is required. So, AST elevation myocardial infarction is a serious type of heart attack caused by a complete blockage in one of the heart's major artery. This blockage stops blood flow to the part of heart muscle, causing the cell in that area to die. Unstable angina. Chest pain is the most common symptom associated with coronary artery disease. It is usually described as dull and can often radiate down the arm or to the jaw. It does not worsen with a deep breath and can be associated with shortness of breath, diaphoresis, nausea, and vomiting. This entire symptoms complex has been termed angina pectoris or the pain in the chest. This phrase was first used by Heberden in 1744. Clinically, angina is classified according to the precipitant and the duration of symptoms. If the pain occurs only with exertion and has been stable over a long period of time, it is termed stable angina. If the pain occurs at rest, it is termed unstable angina. Finally, regardless of the precipitant, if the chest pain persists without interruption for prolonged period and irreversible myocyte damage has occurred, it is termed myocardial infarction. So, unstable angina is a type of chest pain caused by reduced blood flow to the heart. Then, the term angina pectoris, meaning chest pain, was first used by Heberden in 1744. Angina is classified based on what triggers it and how long it lasts. Stable angina happens during physical activity or stress and remains consistent over time. In contrast, unstable angina occurs unexpectedly, even at rest, and can signal worsening heart problem. If chest pain lasts for a long time and leads to permanent heart muscle damage, it is called myocardial infarction. So, unstable angina is a serious and often a warning sign of heart attack.
Now let's discuss the non-modifiable as well as the modifiable risk factors of ACS. First up is the modifiable factors of ACS. First, we have the excessive intake of saturated fats. A diet high in saturated and trans fat can raise cholesterol levels. Next is the drug use, especially cocaine and amphetamines, as these substances can significantly increase heart rate and blood pressure, straining the heart. Next we have is obesity. Obesity is linked to various heart problems, including high blood pressure, high cholesterol, and of course, diabetes. And next, we have the elevated serum triglyceride, total cholesterol, and low density lipoprotein levels. This is due because high cholesterol contributes to plaque buildup in arteries. As mentioned earlier, are the fatty deposits inside the walls, narrowing them and reducing blood flow. Next, we have diabetes. Diabetes damages blood vessels and increases the risk of heart disease. Next is hypertension, as high blood pressure puts additional strain on the heart. And next, the sedentary lifestyle or physical uh, inactivity. This is somehow connected to obesity, as lack of physical activity increases the risk of obesity, which increases the risk of many heart problems, including heart disease. And next is the stress or type A personality, as chronic stress can contribute to high blood pressure and also other heart problems. And lastly, we have smoking, as smoking significantly damages blood vessels and increases the risk of heart attacks. And next, we have the non-modifiable risk factors of acute coronary syndrome or ACS. First up, we have aging. Um, Simply because the risk of heart disease increases with age. Next, we have is gender, specifically for men, as men are generally at higher risk than premenopausal women, but the risk increases significantly for women after menopause. And lastly, we have positive family history, since a family history of heart disease increases your individual risk.
What are the signs and symptoms of acute coronary syndrome? Pallor, or the skin may appear pale, indicating poor blood flow caused by the heart reduced pumping ability. Cool and clammy peripheries, the hands and feet may feel cold and sweaty because of the body is redirecting blood to vital organ. Then blood pressure may be lower than normal or outside normal or higher than normal. Then heart rate may be normal or outside normal parameters, depends on several factors such as pain, ischemia of the conduction system, or the damage to the heart electrical system, and arrhythmias or the irregular heartbeats. So the symptoms: chest pain, or the most common symptoms, described as a squeezing, tightness, or crushing sensation. It is often mistaken for indigestion and typically occur in the center of the chest, sometimes spreading to the arm, jaw, back, or shoulders. Shortness of breath, nausea, sweating, dizziness, fear, and anxiety.
So the next segment is the complication. So what could possibly be the complications of the patient experiencing ACS or experiencing acute coronary syndrome? So first is the cardiac arrest. Next we have arrhythmias and heart failure, hypoxia, cardiogenic shock, ventricular septal defect, myocardial rupture, and pericarditis.
The laboratories and diagnostic tests. First, 12-lead electrocardiogram or ECG or EKG. It records the electrical activity of the heart from multiple angles. The expected outcome or values: if normal, it shows a regular heart rhythm with no significant abnormality. If ST segment elevation or STEMI, it indicates a heart attack where there is complete blockage of a coronary artery. If ST segment depression and STEMI, it suggests a heart attack with partial blockage of a coronary artery or unstable angina. T-wave inversion can indicate heart muscle injury, and other abnormalities can reveal arrhythmias or other heart problems. Then, echocardiogram. It uses sound waves to create moving pictures of the heart. The expected outcomes or value: if normal, it shows normal heart function, size, and structure. If abnormal, it can detect heart muscle damage, heart valve problem, and other abnormalities. Cardiac biomarkers. It is the blood test that measure protein released into the bloodstream when the heart muscle is damaged. It includes troponin, creatinine kinase, myoglobin. Troponin is a protein that is released when the heart is damaged. Creatinine kinase, an enzyme that shows if there is muscle damage including the heart. Myoglobin is a protein released when muscle tissue is damaged, also used to check for heart injury. Then coronary angiography. It is a procedure that uses dye and X-ray to visualize the coronary arteries. Then the expected outcome or values: if normal, it shows no blockage or narrowing in the coronary artery. If abnormal, it identifies blockage or narrowing in the coronary arteries, allowing for treatment planning such as stenting or bypass surgery. Blood tests. A variety of blood tests may be performed, including CBC or complete blood count, blood chemistry. It assesses kidney function, blood sugar, and other important factors. Lipid profile. It measures cholesterol level to assess heart disease risk. Then blood sugar to check for diabetes. Then chest x-ray. It provides an image of the heart and lungs. So the expected outcomes or value: if normal, it shows no abnormalities in the heart or lungs. If abnormal, it may reveal signs of heart failure, such as enlarged heart or other conditions.
Or so now we have come to the more complex part of the report, or the more complex aspect of the report, we have chosen to discuss to you the specific pathophysiology of MI, or a type of ACS, and how it is treated. So the image explain how a heart attack happens and what treatments will be used or what treatments are used. It also shows how a blockage in a heart artery caused by buildup of plaque can lead to a heart attack. And it also shows how treatments like medications and procedures may possibly help. First, the top box shows the change in the condition of plaque in the coronary artery. So this is where it all begins basically. Plaque, a buildup of fatty substances, starts to form inside the coronary arteries, and this plaque can become unstable and may eventually rupture. And of course, next is the activation of platelets, which is a normal response of the body. When the plaque ruptures, it exposes underlying tissue, triggering the activation of platelets. And this can be prevented, or this can be stopped through aspirin, antiplatelet aggregates, and glycoprotein 2B or 3A receptor blockers. And next is the formation of thrombus. So activated platelets clump together, forming a blood clot called the thrombus at the site of the rupture, and this clot eventually blocks the flow of blood through the coronary artery, and this may be treated through thrombolytic therapy, percutaneous transluminal coronary angioplasty. Next, the coronary blood supply less than demand. So the blockage restricts blood flow to the heart muscle, creating an imbalance between the heart's demand for oxygen and the supply it receives. Next is the ischemia of tissue in the region supplied by the artery. The lack of blood flow leads to ischemia, meaning the heart muscles or the heart muscle cells are deprived of oxygen as well as nutrients. And this can eventually be treated by taking nitrates, adrenergic blockers, oxygen, bed rest, vasodilators, and morphine. And next is the myocardial death. So if the blood flow is not restored quickly, the heart muscles the heart muscle cells begin to die, resulting in a heart attack or the myocardial infarction. This myocardial cell death or the myocardial infarction then causes altered depolarization of the myocardium, altered repolarization of the myocardium, release of lysosomal enzymes, anaerobic glycolysis, myocardial irritability, arrhythmias, and decreased contractility. So first we have the altered depolarization of the myocardium. The death of heart muscle cells disrupts the electrical signals that control the heart's rhythm, leading to abnormal heartbeats or so-called arrhythmias, and can cause pathologic Q wave. And next naman we have the altered repolarization of the myocardium, which then causes the ST segment to elevate, and also some T wave changes. And next is the release of lysosomal enzymes, as dying heart muscle cells release enzymes that can damage surrounding tissues, the lysosomal enzymes, which then cause the CKMB to elevate and the lactate dehydrogenase to elevate, the troponin and the myoglobin also to elevate. And next, we have the anaerobic glycolysis. This is when the oxygen supply is limited. The heart muscle cells switch to anaerobic glycolysis, a less efficient way of producing energy, which leads to the production of lactic acid. And as we all know, the lactic acid production can cause angina. However, this can be treated, or this can be prevented through taking a nitroglycerin or by taking morphine. And next is the myocardial irritability. And as shown in the box, we have it showing that it can also cause arrhythmias. So this happens as the changes in the heart muscle due to ischemia and cell death can make the heart more prone to abnormal electrical activity. However, this can be prevented by taking anti-arrhythmias, beta-adrenergic blockers, transcutaneous pacing, and defibrillation. And lastly, we have decreased contractility, as the damaged heart muscle cells cannot contract as effectively, leading to decrease in the heart's pumping ability. This decreased contractility has two causes. First is the decreased left ventricular function, and next is the stimulation of the sympathetic nervous system. First up is the decreased left ventricular function, in which causes increased preload and decreased cardiac output. So increased preload. The heart has to work harder to pump blood against the increased pressure in the left ventricle, and it can be the cause of the increased central venous pressure as well as the increased pulmonary artery wedge pressure, which can be prevented through fluid restriction and by taking diuretics. Next is the decreased cardiac output, which causes decreased left ventricular ejection fraction. However, decreased cardiac output can be prevented by taking angiotensin converting enzyme inhibitors. Also, next is the stimulation of the sympathetic nervous system, which causes increased heart rate, increased afterload, increased oxygen demands. However, this can be prevented through beta adrenergic blockers, which slows heart rate in order to improve blood flow. Increased oxygen demands, as the heart then requires more oxygen to compensate for the increased workload and increased afterload. The heart has to work harder to pump blood against the resistance in the blood vessels, hence the increased afterload, and eventually this can cause vasoconstriction. However, this can be prevented by taking nitrates and vasodilators. Nitrates are medications that relax blood vessels in order to improve blood flow. Meanwhile, vasodilators naman are medications that widen blood vessels to improve the blood flow. And that will be all for the pathophysiology of our report.
Medical, surgical, and pharmacological management of acute coronary syndrome. The initial management includes supplemental oxygen, nitroglycerin or a vasodilator that relaxes blood vessels, reducing the heart's workload and improving blood flow. Morphine, it used to relieve chest pain when nitroglycerin is ineffective. Aspirin, beta blocker, it slows the heart rate and reduces blood pressure, decreasing the heart's workload. And unfractionated heparin, an anticoagulant that helps prevent blood clots. Reperfusion therapy. The aim of treatment is to restore the blood flow to the myocardium in an attempt to salvage any viable cardiac muscle. Reperfusion can be attempted. First, the pharmacologically or thrombolytic therapy. It uses medications like tenecteplase to dissolve the blood clot, blocking the coronary artery. Mechanically, percutaneous coronary intervention or PCI. It is a non-surgical procedure where a thin tube or catheter is inserted into a blood vessel and guided to the blocked coronary artery to open. Then the percutaneous transluminal coronary angioplasty or PTCA. It is a procedure where a balloon-tip catheter is inserted into the blocked artery and inflated to widen it. Then the coronary artery stent or a small wire mesh tube placed in the artery to keep it open after angioplasty. Inpatient management, continuous cardiac monitoring, medications like aspirin, beta blocker, and ACE inhibitor and smoking cessation, nicotine replacement therapy, and counseling to help patients quit smoking. Surgical management. Percutaneous transluminal coronary angioplasty or PTCA. It is a minimally invasive procedure to widen narrowed or blocked coronary arteries. Then the coronary artery stent. A small metal mesh tube inserted into the artery to keep it open after angioplasty, preventing it from narrowing again.
Last, for my part, we have the nursing management. For this segment, we have two types: the immediate nursing management and the preparing for discharge. So, for the immediate nursing management, all patients with confirmed rather, or suspected ACS should be managed in a coronary care unit. Um, Although there are some distinct differences in the treatment of ST elevation ACS and ST elevation ACS, all patients require the following, despite the difference of the acquired type of ACS. First, the continuous cardiac monitoring to observe for any arrhythmias. Vital signs should also be monitored closely to detect any changes in the patient's condition and life-threatening complications, as stated uh, before, the complications. And next is the bed rest. This is for to reduce the myocardial oxygen demand of the patients. Next is the oxygen therapy. So current recommendations dictate that oxygen should not be given routinely, and that the oxygen saturation or the SP O2 levels should be monitored and used to guide oxygen therapy. Optimum SpO2 levels are 94% in patients without chronic obstructive pulmonary disease or COPD, and between 88% and 92% in those with COPD. And number four is the venous access and blood samples. Number five is the 12 lead ECG monitoring when the patient is experiencing symptoms and following every episode of chest pain when the symptoms have subsided. And of course, number six, pain relief, as pain is associated with sympathetic activation, which causes vasoconstriction and increases the workload of the heart. So, the administration of morphine or diamorphine relieves pain as well as anxiety, which is also important um, to be eliminated or to be controlled, and may lead to a lowered threshold for cardiac arrhythmias, and antiemetic should also sometimes be given. And number seven, sublingual GTN if the systolic BP or the systolic blood pressure is greater than 90 millimeters per mercury. 90 mmHg rather than 90 millimeters of mercury. And number eight, the antiplatelet agent, which prevents platelets from adhering to each other and to the atherosclerotic plaques, thereby preventing the formation or extension of thrombus. And number nine is the early risk stratification to assess naman the extent to which patients are at risk of an adverse event such as MI, myocardial infarction, stroke, or even death. And several validated risk scores are available for use in clinical practice, but NICE recommends the Global Registry of Acute Coronary Events, or the GRACE GRACE risk score. Number 10, the secondary prevention of subsequent cardiac events. Of course, um, self-explanatory. And lastly, for the immediate nursing management, the relief of anxiety and support for the patient. Now let's move on to the preparation for discharge. First, of course, is to thoroughly explain the dosages and therapy to promote compliance with the prescribed medication regimen and other treatment measures. We should warn about drug adverse effects and advise the patient to watch for and report signs of toxicity such as anorexia, nausea, vomiting, and yellow vision. For example, if the patient is receiving digoxin. So, number two, review their dietary restrictions with the patient. So, if he must follow a low sodium or low fat and low cholesterol diet, provide a list of foods that he should avoid. We can also ask the dietitian to speak to the patient and his family. And number three is to counsel the patient to resume sexual activity progressively. So, hindi agad-agad. It should be step by step, little by little. And number four, advise the patient to report typical or atypical chest pain, as post-infarction syndrome may develop, producing chest pain that must be differentiated from recurrent MI, pulmonary infarct, or heart failure. And number five, if the patient has a Holter monitor in place, explain its purpose and use. Number six, stress the need to stop smoking. As mentioned earlier, smoking is one of the risk factors, so this should be avoided in order for the syndrome or in order for the disease to not recur. And number seven is to encourage the patient to participate in a cardiac rehabilitation programs, as this may help the patient to be encouraged throughout fighting the post effects or even the um, complications that he or she is still experiencing now. And lastly, is to review the follow up procedures. This includes office visits and schedule testing with the patient.
The prognosis of acute coronary syndrome varies greatly depending on several factors. So, the types of ACS, STEMI, it generally carries a higher risk of complications and mortality compared to non-STEMI. Then the non-STEMI, it is less severe than STEMI but still carries significant risk. Then the unstable angina, it is the least severe type of ACS or acute coronary syndrome but still requires prompt medical attention. Then the time to treatment, early intervention with appropriate medical care significantly improves outcomes. Then the extent of heart damage, the amount of heart muscle damage by the heart attack significantly impact prognosis. Then the presence of complications such as heart failure, arrhythmias, and cardiogenic shock worsen prognosis. Then the risk factor, the presence of other risk factor for heart disease such as diabetes, high blood pressure, and smoking can worsen the prognosis. Then the lifestyle factor, after an acute coronary syndrome event, adhering to a healthy lifestyle including a healthy diet, regular exercise, and smoking cessation is crucial for a long-term prognosis. Then the general considerations, the mortality rates for ACS or acute coronary syndrome have decreased significantly in recent years due to advancement in medical treatment. Then the long-term outlook, many patients with ACS can make a full recovery and return to a normal or near normal lifestyle. However, some experience ongoing complications such as heart failure, arrhythmias, or chronic angina.